Assalamu alaikum. Thank you very much to the scientific committee for asking me to give this talk. I'm really delighted, and it's a great privilege and pleasure to be here to give this talk today. And what I will try to do is to set the stage first to see how bladder cancer has changed, how organ preservation has changed over the years, as well as Maria was mentioning about in terms of bladder preservation, and how we can take things forward as well. One thing which really coming to this meeting today and having heard all these talks today tells me what a wonderful stage this has been set up by Mestro to bring more in-house studies being led by colleagues from here. And on my part, I will always be delighted to help and support these activities. These are my disclosures. We know bladder cancer has got significant morbidity and mortality, large number of cases we see with bladder cancer. And this is one of the most expensive cancers to treat, because even with non-muscle invasive bladder cancers, you're doing surveillance cystoscopies, and those will lead to significant morbidities and also impact on the cost in terms of the treatment related procedures. There remains a debate between cystectomy and organ preservation. And that debate cannot be answered by doing a randomized trial, because there are biases where a surgical colleague might feel cystectomy is the best treatment option, and an oncologist may feel organ preservation is the best treatment option. I feel the answer lies somewhere in the middle, because the patient decides in terms of what the patient wants and what is the best treatment for the patient. And I always say it in front of the urologist when they're sitting there. I've been there in their den as well. And I've said that these two treatments are actually complementary treatments. Surgery and organ preservation are complementary treatments. We need to give the best possible treatment for the patient who will be benefiting from it. So in terms of organ preservation and cystectomy, as I said, there's no head-to-head trial. Previous studies have been done. But if you look at two different sort of studies in terms of both published in JCO, but if you look at like for like, there's not much difference in terms of overall outcomes. Where radiotherapy, if organ preservation has to continue to march forward in improving the outcomes for patients and controlling and getting more share of organ in terms of the bladder treatments rather than cystectomy, it's important that we continue to improve the modality of treatment, improve the outcomes, improve the local control, and with the quality of life data as well. Those are the sort of key things that we need to move forward with. And that is where I would really want to share with you a story that started 20 years ago. And that was part of my doctorate. I was in Birmingham with my colleague and my mentor, Nick James. And we started that trial 20 years ago, which was a phase 1 trial where we added mitomycin C and 5-fluorouracil, which are radiosensitizers. They are very simple drugs to use, very cheap drugs. And in fact, when we published the phase 3 trial in New England Journal of Medicine, there's an accompanying editorial on that article, which talks about cheap and old drugs and new uses. And I think that is important to realize that sometimes some really very sort of, mitomycin C5, if you have been there for many years, how it makes a difference. It does not appear to compromise surgical salvage. And that I'm saying because one thing which I learned most in my career, for example, as a medical oncologist, the person who really contributed a lot to this trial was a surgeon, a urologist, Mike Wallace. I've got huge esteem for him, because what Mike said to me, Syed, if I could not take that bladder out, then we are not doing the right thing. Similarly, he said, if the bladder is not functioning, then again, we are not doing the right thing, because the bladder has to function. So if you're preserving a bladder which is non-functioning, that is of no use. So that's why in the phase 3 trial, we measured bladder capacity as well. So that was something, a brainchild of Mike Wallace, not ours. And that's where it is so important to work collaboratively, to work with different specialities. Oncology is a multidisciplinary specialty where we all have to work together. Then that led to the phase 2 trial, which showed that it was well-tolerated regimen with encouraging efficacy. And that led to the BC 2001 trial, which we worked with myself and Nick in Birmingham, and in ICR, we had Emma Hall and Robert Haddard. And we looked at a similar trial looking at randomization between radical radiotherapy versus concurrent chemoradiotherapy. And other arm was looking at the full bladder radiotherapy versus partial bladder volume radiotherapy. What was key is that it was looking for loco-regional control, late toxicity, and we're looking for 15% improvement in terms of the chemo radiation at 2 years. Acute and late toxicities were looked at, bladder capacity, quality of life, and as I said, bladder capacity was based on the advice of our urology colleagues, and then salvage cystectomy rates. Treatment was given with neoadjuvant chemotherapy was permitted. 118 out of 360 patients received neoadjuvant chemotherapy. That we've already published this last year in European Urology, that part of 118 patients that did not compromise delivery of radical chemoradiotherapy. Mitomycin C was on day 1, 12 mg per meter square, and 5-fluorouracil, 500 milligram per meter square on week 1 and week 4 of radiotherapy. That led to this paper, which was in New England Journal of Medicine, and that changed the standard of care. And that I'm delighted to say in North American trials, which are now being done on organ preservation, they use this regimen as their standard of care arm. So that is how things have changed in that sense. What that trial very clearly showed was that there was an improvement in the loco-regional disease control, significant improvement, almost 1/3 reduction in disease relapse. There was almost half of muscle invasive recurrences. So what you were seeing is that even in cases where recurrences were happening, those recurrences were non-muscle invasive. So patients were retaining their bladders. There was no change in overall survival. And for many of the trainees who will be here, we had a lot of discussions with New England Journal of Medicine editorial team, because they were saying, shall we wait till you have overall survival benefit? And what we went back to them to say, our primary endpoint was local control. These are radiosensitizers. The dose of 5-fluorouracil we are using is unlikely to have an impact on metastasis-free survival. So we should not wait for it. The primary endpoint has been met, and they agreed with it, and they published it. In terms of hazard ratio, if you look at the different whole bladder, partial bladder, 55 grays or 64 grays, or have had neoadjuvant chemo or no neoadjuvant chemo, all favored the use of concurrent chemoradiotherapy. So organ preservation does work in that sense. So that was 2012. More recently, we have published 10-year data, 10-year follow-up with in European Urology last year, and that was looking at a further follow-up, almost 10 years of follow-up with these cases. That has led to a lot of quality of life data that we have. We showed that concurrent chemoradiotherapy does not compromise on quality of life, and this is with the 10-year follow-up data with about 118 months of follow-up. There is no difference in terms of loco-regional disease control. That benefit is still maintained. And what is very interesting is that invasive loco-regional disease remains very well with a very sort of impressive hazard ratio of 0.55. So you're almost halving the risk of invasive recurrences. But in terms of overall survival, there's, again, we can see is a bit of a trend, 49% versus 37%. What is important is that bladder cancer specific survival is starting to show at that point. Again, remember, these are patients with elderly patients with competing morbidities. And I think it is quite interesting to see. This was the first study that was showing that concurrent chemoradiotherapy could be adding into bladder cancer specific survival. So when Professor Pignut asked me to talk more about abscopal effect, and when Nadeem asked me that, can I talk more about it, I was trying to make a story around here. That actually, when we started to see that we are seeing 10 years down the line, there is a benefit with mitomycin 5-FU. So radiotherapy is an amazing tool. And as a medical oncologist, I say that to my radiotherapy colleagues on and off really frequently, because we need to try and see how we can use it more and much earlier in the disease pathways to improve on our cure rates. We'll talk more as we go along. But this was the first time when it was showing that with a 10-year follow-up, improvement in local control, reduced salvage cystectomy, and with known prognostic factors, if you adjust for it, is still improvement in bladder cancer specific survival. So that was interesting and important. What does it do? What does radiotherapy and immunogenic cell death? I think Professor Pignut mentioned in his talk, and it was really starting to set the stage for me, because when we do radiotherapy and we add other systemic treatments, and similarly now with immune checkpoint inhibitors around, how do we use them? Because I think one of the key things where patients start to get the resistance, and resistance could be with chemotherapy. We have learned in our clinical trials, for example, that sometimes combination chemotherapy did not work, but maintenance immunotherapy, immune checkpoint inhibitors work. So there is a microenvironment story here. And I think with the young colleagues here who are planning to do PhDs or are thinking about doing some research around it, this is a huge and exciting topic to look at, that what are the impact on microenvironment when you're looking at that. So, in terms of the irradiated tumor, then radiation-induced immunogenic cell death, then how it leads to cross-priming, and then it leads to local and abscopal anti-tumor effects. So there are definitely, significant things to think about in terms of the local control, because when I'm talking about the bladder cancer specific survival, was that all linked to the improved local control, or was there something else to it? And that is something we need to dissect more. And if you have got tissues and sort of samples, serial time points, you can answer that. That is where we're doing radio trial, which is adding exactly the same mitomycin C5FU, but we have added radiotherapy with radiotherapy, concurrent radiotherapy. We have added durvalumab into it. And durvalumab is an immune checkpoint inhibitor, which is basically trying, the whole point is to try and see whether that will improve. It can augment the effect of radiotherapy and concurrent chemotherapy in muscle invasive bladder cancer. And in that sense, may help improve local control and reduce systemic spread. Because we are starting to see that actually by using these drugs early, you can make an impact on the disease control as well. So radio is a multi-stage randomized trial, which myself, Professor James and Shaista Hafiz from ICR, we are all working on it and looking at durvalumab in combination. Control arm is mitomycin C5FU, and the research arm is additional durvalumab. There was a study that was presented by my friend and colleague Arjun Balar, and that was quite interesting. That was with pembrolizumab in combination with gemcitabine and concurrent hypofractionated radiotherapy treatment in muscle invasive urothelial cancer. And again, the whole point was that key thing was that to see whether PD-L1, which is active, that leads to durable responses in urothelial cancer. And there is evidence to suggest that actually PD-1 blockade and chemoradiation works in synergy. And how can we use that synergy to improve the outcome? So this study looked at safety and efficacy of pembrolizumab. Phase 1, phase 2 study it was, looking at pembrolizumab and the maximal GURBT and 4 weeks of chemoradiation. And baseline characteristics in the phase 1, which was 6 patients, phase 2, which was 48 patients, was very similar. Characteristics, there's no sort of, this is standard what we see in our muscle invasive bladder cancer practices. What was interesting was that the 12-week post-RT response rate, 83% in the in the first cohort, and overall post-RT response rate was basically 48%, and if you look at the whole 54 patients, 59%. So again, this is the complete response rates that we are seeing, CR rates. So this is not just any response, it is a complete response rate. So that is encouraging. These are early days of concurrent chemoradiation with immune checkpoint inhibitors. But from this sort of a stage, this sort of a platform, I really feel these are sort of studies that, the colleagues here are, Zahid, Zahid with the Qaboos University and all, Nadeem and Professor Pignut, you have to think about whether these sort of studies should come in from these centers, because what is driving the response and what is driving the resistance in Caucasian patient population, all these studies we're talking about are linked with Caucasian patient population. But if you look at these studies in our Asian patient population, I was at Shaukat Khanum Hospital last weekend, and we talked about these sort of studies to come from Pakistan, for that to come from Middle East, from Saudi Arabia. I think that is key to see, because you might find the driver of resistance and response may be different. So this was quite interesting. Bladder intact disease-free survival in all patients, if you look at, was 89% at 1 year. This is really interesting data, because 1 year disease, bladder intact disease-free survival. So patient has not lost the bladder and there's no other disease anywhere else. Similarly, metastasis-free survival was 85% at 1 year. And we know that the risk of bladder relapse is maximum during the first 24 months. First year is the maximum, and then second year, and then the relapse. Relapse doesn't go away, and that's why any patient, when we ask for organ preservation, we always tell them that there's a high risk that the disease may come back. We have lost bladders 10 years down the line of our patients. But again, patients do feel that if they can keep their bladder for 1 more year extra, that would be good for them. So that is how you need to look at that. So metastasis-free survival improved. Treatment-related toxicities, there was no extra, sort of a data that came out. in terms of the toxicities. In terms of combination, in the first patient, there was one patient who had grade 4 colonic perforation, but he developed multiple complications. So one patient did die of that with multiple complications. And again, for phase 1-2 trial, you have to document all those toxicities and data very carefully. That's the key thing, that when you're adding out of those one patient, 54 out of 54 patients. In terms of the risk related to the immune checkpoint inhibitors, there was some arthritis, transaminitis, one nephritis, one protein. And again, that is the important reason I wanted to put it in, because if you want to work together, it's important that the clinical oncology colleagues are more involved in toxicity, in understanding the toxicity and managing the toxicity of these immune checkpoint inhibitors as well. Because the key thing, when we treat these patients in advanced metastatic setting, I do re-challenge them. Once or twice I've re-challenged. Often one patient who gets hepatitis grade 3, we can challenge them with the steroid and then re-challenge them with the immune checkpoint inhibitor. So you can get much more benefit. But the key thing is understanding that this is immune-induced diarrhea, not radiation-induced diarrhea. And sometimes that could be quite difficult to delineate. But the more you see these patients, the more it will, and seeing some of the fellows who are around, it will be very useful to get more feeling for the toxicity profile of these drugs as well. In normal immune responses, you get T-cell activation and tumor attack. In the tumor, immune evasion happens, and that is the thing where when we look at PD-1 blockade and things, the immune checkpoint inhibitors, that's where they have made the big difference. T-cell inactivation through the PD-1 immune checkpoint is going to be the key here. And then what happens when normal immune response is restored? And that is where I was talking about the microenvironment. And that is where tumor biology and translational oncologists come into play. There were a couple of colleagues who asked me about some PhD projects they are doing, and they were talking about, and I do feel that if you are doing in a big center where there are a number of patients, if you start to get serial samples, whether it's ideally if it's tissues at different time points, and you start to look at, you might find that the microenvironment changes at the time of progression, at the time of metastatic disease. And I think that's where we will learn more about abscopal effect as we go along as well, because that is mediated by systemic anti-tumor response. And that is regression of non-irradiated metastatic lesions at a distance from the primary site of irradiation. That is more like a bystander effect. That's what you're looking for when you're looking at abscopal. And again, you talk to different people, some will say it's just a myth, it's not real. They will say it's just a hypothesis. Yes, it may be hypothesis generating, but we need clinical trials. We need patients to be getting radiotherapy when the disease starts to progress. And we are doing some trials that I will talk to you later on. But by documenting, so what we are trying to see, this is some of the work that we published with my one of my very wonderful colleague and friend, Dr. Jawahir Ansari. He has moved to Middle East about 7-8 years ago, and now he's in UAE. But so some of the data, we looked at some patients with multiple treatment, sort of a disease sites and multiple treatment sites. That was more with lung cancer and kidney cancer. I've got a case that I was present about the bladder cancer as well. And patient with cisplatin alimta, progressive disease, partial response initially, then maintenance alimta, then progressive disease, then docetaxel chemo, then on Tarceva, and then nivolumab commenced in April 2016. And again, April 2016, quite a large lesion, which was growing. And then once you give radiotherapy treatment to that site, you start to see some response, bystander responses in other areas as well. So the lung lesions have improved significantly. And that was a significant treatment response that was seen. And then there was adrenal metastasis seen, which was again irradiated. And then there was again some response in the lung lesions. So, these are sort of things, these are case reports, there are meta sort of analysis. And that's why a platform here as well helps, that you've got colleagues from Pakistan, you've got colleagues from all around the Middle East to think about cases to bring together and try and publish it. And you've got some really wonderful trainees around and senior sort of radiation final year trainees and things like that. It's really great projects for them to really make it out, bring it to big meetings and present it at ESMO and other meetings. So abscopal effect is looking at the effect of ionizing radiation on cancer outside the radiation field. So which is basically what you're trying to see in that case. This was the other case looking at alimta 5 cycles, then followed by maintenance alimta, and then docetaxel, and then Zometa. Patient progressed with brain, lung, and bone metastasis. Nivolumab in July 2016, you can see a big brain lesion which responded to radiotherapy. And there were other lesions that started to improve as well. So again, this is not, there is definitely something going on by continuing with immune checkpoint inhibitor. And we have seen in a number of cases, we treat a lot of patients with immune checkpoint inhibitors, and sometimes you see that the tumor is progressing, but the tumor still continues to, if you carry on with that and give some radiotherapy in between, you do see sometimes that if there was some symptomatic sites, they start to improve, but also there is a regression of the tumor, which is important to understand as well. So 7 of the 17 patients we talked about radiotherapy. Of the 14 measurable lesions, 86% had excellent response with a complete response of 3 lesions. Symptomatic benefit were observed in 4 of 6 of these cases. There was 1 case of grade 1 pneumonitis in 2 patients. There were no grade 3-4 toxicities. So when we look at the non-target cell response, you're looking at the ionizing radiation used in cancer, targeting the cancer cells, but it is also targeting the neighboring healthy cells. And that's why when we talk about the improvement in radiotherapy techniques, which we talked during the day today, that makes a big difference because you are reducing the toxicity and you're reducing the morbidity, and that is going to have a better impact because your radiation dose can be increased if required. In terms of the indirect effects are the bystander effects on the non-irradiated cells. And that is where the use of immune checkpoint inhibitors and other chemotherapeutic agents come into play. And these signaling molecules can trigger a variety of responses in neighboring cells, including DNA damage, changes in gene expression, and cellular damage. And the reason I talk about microenvironment is that that is something we need to try and answer that. What happens actually? Because that is where it becomes, where basically we're trying to find an answer to that. That is that change in the microenvironment that is leading to the big impact in the responses. Antigen release is there with the releasing tumor antigens. These can attract T cells to tumor sites. This is more like a hypothetical scenario how we are moving with immune checkpoint inhibitors. So radiation can increase the expression of PD-L1. And by increasing the expression of PD-L1, this provides more targets for PD-L1 inhibitors, which can then block the PD-L1 interaction and relieve the T cell suppression. And again, you will have heard about a lot of debates going on about cold, when we look at the cold and hot in terms of the immune signatures, in terms of the immune deserts, there's always a theory, is there a reality? Is there an immune desert tumor? Is there an immune more like a tumor which will respond more to these immune checkpoint inhibitors, and then by certain treatments, they become immune desert? Does radiotherapy at that point invigorates those T cell responses and the PD-L1 response axis, which helps you to get a better response? So there are things that we can really get out from it and get much better understanding of that. So this combination of radiation in these sort of scenarios has the potential to enhance the abscopal effect. So molecular changes underlying release, we've talked about that in terms of antigens, T cell priming and activation, and immune checkpoint regulation. So the other thing which is important, and I think we were just having discussions like activation of dendritic cells as well, because that is where you can see better response. Radiation can activate dendritic cells, which can then migrate to the irradiated tumor site to capture and present the tumor antigen to T cells. So there definitely are really very plausible reasons and think why it will work better together. So I think we need to try and find that out. This was a really interesting 61-year-old lady from Doncaster who presented with blood in the urine, and she was very well and fit, but had G3 advanced muscle invasive urothelial cancer. CT scan had shown mediastinal nodes and liver mets. So she had GemCis chemo between May to August 2019, progressed, then had atezolizumab that started in December 2019. Then she had significant pain. The tumor was progressing. And that is when we gave some radiotherapy to the bladder with one of my clinical oncology colleagues. And, we carried on atezolizumab. And that patient continued to respond to atezolizumab for 2 years. So she had almost 2 years of, she completed 2 years, which is allowed to us, 2 years of atezolizumab treatment in advanced setting with excellent response. She died in October 22. But considering that she presented in March 2019 with the liver mets, and you can think the median survival with liver metastasis stage 4 bladder cancer is about 15 months. And this lady lived for about more than 3 years. So I think these are sort of 30, say, about 42 months from March 2019 to October 22. So these things have big impact on outcomes as well. And scans which were done looking at the April 2019 scan, then post-chemotherapy, the tumor was progressing. Then post-cycle 2 atezolizumab, the tumor was growing. Then she had radiotherapy, and then that mass remained quite well, and that was basically, the other lesion, liver lesion, did not grow at all. So I think that is where what is interesting and important. There are bladder sparing trials that are going on with neoadjuvant chemotherapy and immunotherapy. I was talking to Nadeem and to other colleagues as well. There are huge opportunities to do organ preservation trial from Middle East. Mestro is providing you a platform to get all your colleagues from different parts of the country, involve Pakistan, involve Nadeem, Abbasi, and all the other colleagues around to see where we can do. Because I think we've got PAEC here as well with Dr. Fahim and things. Wherever there are high load of patients with bladder cancer, think about, can we do an organ preservation treatment coming from our part of the world? Bladder sparing with immunotherapy region 2, which is looking at the biomarkers as well, where you may not lose bladder at all. And this is a bladder sparing trial with neoadjuvant chemo and immunotherapy. Patient may have no cystectomy if they have got complete response, or cystectomy, or if they have not a complete clinical response, then they will have cystectomy. So there are different ways of doing these trials, and I just wanted to throw those designs. We're very happy to discuss that in later. REARM is a study which is a concept which is looking at adding, and this is led by my colleague Robert Haddad from Institute of Cancer Research, which is adding basically the same concept. Cold tumor becomes hot tumor by giving radiotherapy treatment. And again, this is looking at unblinded randomized trial of atezolizumab until progression, or atezolizumab 1200 followed by radiotherapy until progression. So you give 20 grays in 5 fractions of radiotherapy treatment to get that response back. So that is an interesting trial, usually radiotherapy to single metastasis, 20 gray in 5 fractions. Just to finish with, this is really interesting because this is something that has just come out last week. We've started that trial. This is precision medicine, looking at different types of bladder tumors, subtyping of bladder cancer, luminal, which is luminal papillary, luminal infiltrated, luminal basal squamous, or neuronal. So this is the staging done on Caucasian patient population. And I don't know what will be if we do our patients from Middle East, or if we do it from Asian countries, from Pakistan, for example. So that is something we should do. In one of the discussions, it was discussed about subtyping of the cancers we should be doing in our patients to find out what is best for our patients. Because that led to this trial, which has just opened, which is basically randomizing patients in UK. This is funded by NIHR, EME, MRC funding. Jim Cato and myself and Simon Crabb are running that trial. That is randomizing patients between these 3 different. So patients get standard of care neoadjuvant chemo followed by cystectomy, or subtype defined treatment, which could be chemotherapy plus immune checkpoint, durvalumab plus tremelimumab, or in certain cases, for example, if they have got luminal papillary, they may go straight to radical curative treatment without any chemotherapy. So you're sparing the toxicity and the cost of chemotherapy in cases. Similarly, you are escalating the immunotherapy by adding immunotherapy into chemotherapy in certain cases. So that's a really interesting trial. That is, I think, the future of oncology, that we subtype the patients and treat patients accordingly. And again, all these trials I've talked about, a lot of that we have worked and led from Sheffield. And again, it's only possible because a huge amount of wonderful colleagues that we have, and we work together in that. And on that note, I will thank you, and thank you again for the invitation to give this talk.